mewing problems. We're taking comments off YouTube and we're going to go through them one at a time, and I'm going to give you just, a straight up quick response, and I hope this is helpful. Clearly my life has been thrown in once again to disarray, but I'm here wanting to help people. We are working to build myself back up again, and it's one step at a time. Here we go. So the first question is from @TamuBlocks, I think. It says, I can't get a vacuum hold no matter what I do. Now, clearly practice makes perfect, and a lot of people who I've worked with who say they can't get a suction hold, vacuum hold, same thing. They just haven't practiced hard enough. So do continue to work. But if you can't really get a vacuum hold, the number one problem is anatomy. It nearly always is. And 2 points. One is that you either lack tongue space, so you can't get your tongue up onto the roof of the mouth without the tongue folding somehow, or that you've got a very high narrow palate, and that narrowness continues out along the back. And when it carries out along the back, that's then preventing you from getting a suction hold. Now, the tongue is an amazingly adaptable organ. This was clearly one of the interesting responses in my court case, where the prosecution orthodontist was saying, oh, the tongue will fit into any space, it's adaptable, it's malleable. Well, it is adaptable, malleable, but it still exerts some outward pressure, and that outward pressure will still then eventually cause change. And the problem here you're going to find is that you've got to make a decision whether you really can't get that tongue up there. And if you really can't get that tongue up there, you might need some artificial assistance, something like expansion. That's nearly always going to be the answer here. And whereas 20 to 30 years ago, my father, and then 20 years ago, I was doing tooth-borne expansion. That's where you clip onto the teeth and you can get expansion. And it would appear we got good results and some stable results from doing that. I think now, humanity's moved. We're on this slippery slope, and what it appears to me is we've gone down this slippery slope. And I have had some success with adult tooth-borne expansion, but I would generally recommend people now use either a surgical assist, which I had some good results with, or some bone-borne expansion. So that's where the expansion uses TADs, which are effectively screws that screw into the top jaw and gain some expansion. Now, most people are going to do that as part of a broader orthodontic therapy. Sometimes I think that's a mistake. I think sometimes it's what I often felt when I was doing orthodontics, particularly when I was working in the university where I trained to do orthodontics. And I sometimes think it's that there's the final finishing and tidying up and perfecting it to make it look really good, that sometimes it's just in the interest of the ego of the orthodontist and not in your interest, because get out as soon as possible. Get all stuff out the mouth, particularly anything that's preventing the teeth coming together comfortably. Okay, so just get the bite comfortable as soon as possible. And of course, if you are going to do any form of expansion, you're going to, what I refer to as, break the buccal segments. So we talk the buccal side teeth. This is the buccinator muscle, so the side teeth. And of course, as soon as you start widening the top jaw, and you're not. Very few people actually do widen the bottom jaw. I did. We got some really good results with it. But most orthodontists don't. So we would aim to get... you'd widen at a different rate anyway, sorry. So you would end up widening the top first and then the bottom, and then letting the top go a little bit so it dropped onto the bottom, and then the teeth just settle. They settle quite quickly, but they settle best if there's nothing preventing the teeth from settling. So if you can wear a lower appliance that will hold the lower teeth, that will influence their position. And that's fine as long as nothing's influencing the position of the teeth in the upper arch. Then they will settle nicely. But if you've got something influencing the position of both upper and lower teeth, then you're always going to struggle to get the teeth to bite together really comfortably. And a good way to test this is just do it little mini bites. And if the teeth just bite together completely harmoniously, great. You've got a nice, comfortable bite. But if the teeth are moving around, I worry about that. And I worry with long-term retention on that issue. Anyway, enough on that. The next question here is Herman Ravionson. Sorry, I'm not a very good reader. I still have the reading age of a 12-year-old. He says, is mewing good if I have a malocclusion type 3, aka underplay? So when we look at malocclusion, we're looking at 3 generic types of malocclusion, particularly according to Angle. Angle had he was noticing the back molar, tooth number 6 should fit together like this. So the top back tooth number 6 is behind bottom back tooth number 6. So effectively they would bite together kind of like that, got 2 cusps, at least from the outside, and those 2 cusps would bite together like that. Okay. If you think all 4 front top teeth are a lot bigger than the 4 front bottom teeth. Okay. So you can have the bottom molars are here. They go around the same number of teeth, top molars, same number of teeth, but because of these bigger upper front teeth, the top teeth can be slightly further outside the bottom teeth, and so you have a greater perimeter distance, but also take up more space so the teeth are set further back. Okay? Now, Angle had this big thing. He really focused on that tooth at the back, that position tooth, and he was saying that if the tooth was there, you were class 1. If the bottom jaw was set forwards, you were class 3. If the bottom tooth was set back, you were class 2. From a visual perspective, a class 2 would be like this, and a class 3 would be this. Now, Herman, my thinking on this is that Angle was, he was a really interesting chap, well ahead of his time. He had a load of really good ideas, but he was within the paradigm of the era that he was in, and at that time people had much better general dental development, and I think facial development, I call it skeletal development. So I think what's happened is we look at the front teeth. All right, so this is how the front teeth fit together in the modern world. In the ancient world, they wore down so they would fit together, and of course the bottom jaw came forward a little bit into what we almost refer as a pseudo class 3. So when you look at ancient skulls, most of them bit together edge to edge, and we refer to as a pseudo class 3. But today we don't have nearly as much wear because we have softer food, and of course we have knives, so we don't have to incise like that. You see? So instantly, as soon as you have a knife, you've dramatically changed your lifestyle. And of course, you don't find any peoples alive today, even a lot of the more indigenous peoples, they're not, they have knives, and they're, I would say, in my opinion, they're halfway to where we are in a modern world. Anyway, so I think that our ancestors, if you're looking at the front teeth, were up here, okay? And what's happened, as we've got craniofacial dystrophy, we've dropped down here. Here are the people who are class, so you drop down to here, you have a class 1, modern, good, nice, developed face, no problem, you even get your wisdom teeth in. You drop down to here, you have a nice, modern, class 1, but you don't get your wisdom teeth in. You drop down to here, you've got a class 1, but you probably need teeth taken out, as well as your wisdom teeth being lost. So you've got a crowded class 1. All right, so then you've got the class 2, and you've got the class 3. Well, in effect, Herman, you still need to go up in this direction. And realistically, trying to get the maxilla up and forwards, that's your goal. Now, if you are over 25, it's incredibly difficult to change. Listen, change is not easy. But I would say that you've got a chance of changing if you are under 25, and you really. The problem is not so much how difficult it is physically to do; it's how difficult it is to remember to do it. Here's the problem. Here's the kicker. It's not that hard. Lips together, teeth together, tongue on the roof of the mouth. Or when I say teeth together, I mean together in butterfly bite. Okay, but if you've got the tongue on the roof of the mouth, you've got that natural antagonism working. So I don't think in my belief, you're not going to clench. The problem with clenching is when your teeth come together and the tongue's not on the roof of the mouth, acting as a natural antagonist. But Herman, mewing is the answer. Whether you're going to get a huge amount of structural change depends on you, and I warn you, it's not easy. But don't forget, if you don't do it, you could get worse over time. Most people go south. Remember, as soon as you hit like 35, everything's going to go south. You're going to get older. So realistically, you either want to try and gain a real proper change through a lot of mewing, or you're going to try and prevent yourself getting worse over time. These are two slightly different strategies. Now, the problem with getting changes through mewing, it's unlikely, if your teeth are literally the wrong way around, that will self-correct. I've seen individuals, I'll never forget, there's one individual who had an overjet. So the opposite way, you've got an underbite here, and he had an overjet. And I was treating this individual, and we were using appliances. So, we were teaching him mewing, yes, but also we were using appliances. So it's a slightly different situation. And I was measuring the overjet, and we were measuring the overjet, and so each time he would come, he was being held here on the brace, then he was coming back, and I'd be measuring this distance. And we've been doing about 6 months, maybe 9 months, and we really weren't seeing much headway. And every time we measured it, and at one point the mother said, "Look, Dr. Mew," I'm Michael, first name terms with all my patients. She said, "Look, what are we going to do? Yeah, we don't seem to be making much headway." And I go, yeah, overjet seems to be staying exactly the same. Anyway, so I picked up the original photograph because we were really big on looking. We produced brilliant photographs. We really had good handle on what was going on from these photographs. And I put up the photograph. I held the photograph. I looked at the child. I showed the mum the photograph. She looks at the photograph. She looks outside and goes, "Yeah, let's carry on." Because we'd got such huge change. So yes, he had an overjet. Yes, and I was using this as my marker of the improvement he was gaining. However, that overjet was moving up like this. Whole thing was moving up, intact, if you will. And the facial change was just, really impressive. And I was just I never get the mother, she looks at me and goes, "Yeah, I think we'll carry on." And it was just, an interesting sight. So this is from, now I'm trying to get this right, Parexit 8887. Yeah, maybe got that right. Okay, so he says, "My lower teeth is back from front teeth. What should I do? Eye teeth is not in correct position." Now, I'm guessing that English isn't your first language. And it's not for me to criticise because there's a joke here. What do you call someone that speaks 3 languages? Trilingual. What do you call someone that speaks 2 languages? Bilingual. What do you call someone that speaks 1 language? English. So I only speak 1 language. Now, to be fair, they stopped my French because it was a legal requirement in Britain. I think it still is, but it certainly was at the time, that you would speak another language. And they stopped me because I got special exemption because I was dyslexic. And remember, I was diagnosed as dyslexic back in the 70s. And that was rare, really, really rare back then. I must have stood out like a sore thumb. Now, okay, to be honest, the answers are more or less exactly the same as I just said for the last gentleman. Who was that? That was what I did for Herman. You've got to get your tongue up on the roof of the mouth. Mewing is unlikely at your ages. Guys, most of you are grown, you're fully grown. Gaining real structural change, it's very possible. Look, there's hundreds of results of people doing it. Problem is you remembering to do it. But it's hard work. And it's you want to do this because you don't want to get worse, and you do have the opportunity of improving. Yeah? And of course, my role here, my goal is to help this whole science to move everything forward, to make it easier for you, so that you can get going with gaining improvements. But it's not easy. And again, if you do have your lower teeth, reverse overjet, so swap back like this. I don't think mewing, everything's going to move north together. You're going to take this whole structure as it is and you're going to move it up and forwards because you're going to deal with it as one. When you're mewing, always put your teeth back together in their normal, comfortable position. You're not going to try and cross over when you do it or cross behind as you do it. In theory, if you did that, yeah, you could get a correction, but that's not comfortable. It's not comfortable. You're not going to maintain that position. If you're not going to maintain that position, you're not going to get change. That's how it works. So, and remember, most of you are fully grown, so it's hard to get change. However, it's obvious from someone who has a stroke that you can get dramatic change at any age group. We just need to work out, we need to get better. Here, welcome to the mission, you're early adopters. You can either wait 10 years or get cracking. All right, so now we've got, this is an unpronounceable name, it's at RWWRJ. So there aren't any vowels in it, so you can't pronounce it. So it says, hey Mike, ever since I started mewing correctly, with the back third of my tongue on the palate, along with the rest of my tongue, I've developed what feels like TMD. I have symptoms like jaw stiffness and my jaw shifts to the right when I close it. I'm wondering if you have any advice if I should take a break from mewing, if this is the root cause. Many thanks. Well, okay, so your TMD, jaw joint problems, temporomandibular dysfunction. So you have a temporomandibular joint, okay? This is the temporal bone, this is the mandible. So the joint that meets together is called the temporomandibular joint. And it can get problems. It's a very, very special joint. It's the second most complex joint after the knee. But one of the things with the jaw joint is that it's really good at working even if it's really messed up. It can be effed and it will still work because, you know, you imagine you damage your knee, the knee can seize up. And, well, how's that going to damage? You know, if you're on a hunt, yes, that can be a real problem. But I presume you're on a hunt, you could A, limp home, or B, get some friends to help you limp home. However, if your jaw seizes up and you can't open your mouth, you'll die. There's no question. So the jaw joint is really good at working even if it's quite messed up. And in a way that's possibly not good because that will just help you mess up even more. So the main problem with jaw joints is people having a subliminal problem, a mild problem, and then suddenly going into a gargantuan chewing marathon. And too many mewers do this. In theory, and I've had a lot of response back from mewers saying that it helps with their jaw joint problems. So, you know, there's a couple of different things. You could have got this, it was just coincidental, you got the jaw joint problem flaring up now. A lot of mewers are in their late teens, early 20s. And a real high point for jaw joint problems, TMD, is exams. So I remember someone saying that statistically most common person to get jaw joint problems were teenage girls at 16 or 18, which is in Britain when they do their exams. And so, you know, you're in this age group where you might have a problem coming up. And of course, this is a relatively recent comment. So it's exam season, or was exam season. So that is a real common cause of it. The other one is going on a chewing marathon. And of course, the other one is mewing badly. So doing something completely wrong, particularly leaving your tongue between your teeth. Okay. Now, yes, one problem mewing can do. As you bring your teeth fully together, then that can lead to problems, okay? Because I think that the jaw joint problem is because there's a disassociation. You rest in one place, okay? Usually with your teeth quite separated. The jaw joint forms in that position because that's where you are all the time. Then you bite together with your teeth together, and that's an overclosed position. And most joints don't fare well when they're overclosed. And what happens? And of course, you've got this problem you mentioned here, your jaw's shifting to the right when you close it. Well, as you're closing, you've caused some damage in one of the jaw joints. They might be a little bit asymmetric. Most people usually are. So one joint is overclosing a little bit more, might be a bit damaged. There's a bit of inflammation there. So then the disc, because this is a 3-part joint. You have the mandible has a ball in it. Then you have recess in the temporal joint, and you have a disc in between, which allows 2 types of movement. And that disc is being squeezed out, and then it can get squeezed into all different positions. And so it's really a real common thing that when that disc is either squeezed out or it jumps out or something goes wrong, that can lead to asymmetries in the place of the jaw. So yes, this is a real sign of jaw joint problems, so be careful. Stop chewing, okay? And it's probably worth going and getting a professional opinion at this point. I mean, the common thing to do with jaw joints is to use splints. Now, if I were to be critical of jaw joint problems, I would say splints are often simply filling up the space where you would normally leave your tongue. Okay, so the jaw joints, you hung your mouth open slightly, the jaw with your tongue between your teeth a bit. Your jaw joint is reformed to that position, so when you bite together, you're overclosed. Put in a splint, well, then you're not overclosed. You're biting together in a position where that matches, so your postural position now matches where the splint is. And they can be very effective. I think the general research comes out that there's hundreds of different ways to treat jaw joint problems. So many different ways. Some of them have to be wrong. That just is a bit strange how many different ways there are. But as a general rule, is they all have about a 50% 5-year success rate. Okay. Problem with splints sometimes is you get addicted to them. And a lot of people then rest their tongue, because they were used to resting their tongue, and they rest between the teeth. They rest the tongue over the top of the splint. Now they open up even wider, then the splint needs to be built up even more. And if you go down that direction, that can be a real problem. So I much prefer the practitioners that only tend to recommend splint wear part-time, not full-time, because then you don't get so much as addiction or this addition problem with those splints. But there are, there's lots of exercises. So many things. There's lots of good exercises that you can do. I mean, there's from everything from physiotherapy to grinding teeth to injecting saline to injecting steroids to putting botulism toxin in the muscles. I mean, it just goes on and on. There's so many different. Anyway, listen. It's just be careful. Go and see a professional now. Is the top advice on that one. I don't necessarily think if you're mewing well, I don't think that's going to cause you problems. Okay, do careful about trying to get your teeth together though. That can be a problematic element. But go and see a professional. I think it's about time. You've got signs. Jaw joints can go on to ruin lives. Be careful. The Great Mewing Event. It's going to be the 6th of September in central London. This is an opportunity to meet me, to meet several other select speakers that I have selected that understand this field, this concept, and they're coming in from different angles. And there is nothing like meeting us in person, asking questions, and getting a real better idea on what's going on, how you can help yourself improve. Listen, 6th of September, see you there.